So it falls to me to have this very happy opportunity to welcome you all to the launch of the Patient Perspectives on COVID-19 projects. And we're actually going to be talking today about 4 projects which we and colleagues have been running over the last 3 years. Now, it does seem quite extraordinary that it is almost exactly 3 years, more or less. Some people, I think, were onto this slightly quicker than others, but more or less 3 years since we first became aware that we were heading into a pandemic that was going to seriously affect all of our lives. And we set this date quite a while ago of the 15th of March. I always like doing things on the Ides of March. It seems, portentous. And it seems to be by complete coincidence, as far as I know, that this has been adopted as Long COVID Awareness Day. So that's fantastic. And we're going to be talking about 2 projects, amongst others, on long COVID. Now, just before we get started properly, I would like to check that people are content for us to record the first part of this meeting. The first part of this meeting is basically where we're talking, and then we thought we'd stop recording by the time we have the wider discussion. But if anybody isn't happy with the meeting being recorded, could you please say so now, or we'll put it in the chat if you're not, otherwise Ruth will be recording. Thank you very much. I promise we'll only do fair and decent things with it. So on this session today, I'm absolutely delighted that we've got the research teams who are responsible for doing this work, and we've invited the funders, and some of them are here, policymakers, clinicians, and also fantastically we've got people who took part in the interviews. So it's brilliant to be able to have them here so that they can see some of the things that we've been doing, often with their guidance on the research. All right, and if we could have the next slide. Thank you. And actually, that's quite funny, isn't it? That's become quite a next slide, please. After all those Downing Street presentations, that all slipped into the vernacular. Anyway, so what we're going to do this morning, a little bit from me on the background to the research studies, and then we're going to talk about just very briefly some of the main findings from these 4 connected studies. Intensive care experiences, the PI was Lisa Hinton from this institute. Long COVID in adults, which was funded by the Chief Scientist Office in Scotland, and the PI was Kate Hunt. And then 2 that were run from our group, Long COVID in families, funded by NIHR, and Inequalities, which was diverse experiences, which was funded by ESRC. And you'll hear from about these from the researchers involved. Now, somebody has got their microphone on and might just want to check because we can hear typing. Thanks, Trish. All right, and then we're going to have some reflections from discussants. So we've got 2 fantastic discussants here. We've got Professors Nisreen Alwan, who's been very central in a lot of the discussions around COVID and long COVID, and also Professor Trish Greenhalgh. So thank you both very much indeed. And they're going to say a few words, immediate reflections, after we've presented the 4 studies. We will then have a comfort break for a few minutes, and then we'll bring everybody back for a bit more discussion and some questions and answers. Okay, next slide, please. Very important that we acknowledge our collaborators and funders for this project. And we had funding from NIHR Chief Scientist Office, the ESRC, and also supporting Savante Wild, who's doing the driving at the moment, and also speaking to you later. Funding from the Girdlers Fellowship, which sends a talented postdoc scholar to the UK from New Zealand, and we've been incredibly lucky having Savante with us during these projects. And of course, the team is spread far and wide across Scotland and England. Yes, Oxford, but also Stirling, Aberdeen, Edinburgh, Cambridge, the Open University, Bristol, and the London School of Hygiene Tropical Medicine. And here you'll also see the logo for the Health Talk platform, which is where all 4 of these studies, with hundreds of video and audio clips from the interviews, as well as lots of pages of analysis, the hard work of the researchers, are all published on a public-facing platform. And it's fantastic to have people here from the DIPEX charity that runs the Health Talk site as well. So next slide, please. And the next slide has got a list of all the people who were involved, and I'm not going to spend a lot of time reading through all of these names, but these are the people who, failed with this entire project as co-applicants raising the funding, as advisors on our advisory panels, our public involvement advisors, of whom there were many, the fabulous Performing Medicine, who've been working with us to translate our findings into interactive theatre workshops, and of course the research teams themselves and the many supporters in administration. So thank you to everybody. It's taken a lot. I mean, I often say there isn't much division of labour in qualitative research. I give this impression that the lone ethnographer goes out into the field and does it all. But, just look at the number of people who've been involved in this study, and we're incredibly grateful to all of you, working often in difficult circumstances, and pretty much everybody's got COVID at some point during this study. Okay, onto the background. Next slide. Thank you. So a few of the things that I just wanted to mention as we get started is the context when we first applied for funding for these projects back in 2020, and it seems a bit ironic now, but one of the concerns that many of us had at that time was that by the time we'd done the research, the pandemic might have gone away. It's quite hard to think back into that mindset now, but we really did think if we were collecting people's experiences, their narratives of the early days of COVID, then who was going to be interested in this other than for perhaps in some historical archive? Well, just goes to show, be careful what you wish for. But in those early days, there was, I think, very understandably, a focus on the numbers and looking for treatments. It was, a lot of it was around the epidemiology and how we could best treat people. And I think that's perfectly reasonable in the early stages. But of course, this was also an extraordinary event affecting our society and people's relationships, and as we all remember, our ability to socialise and go to work. And we have, as qualitative researchers, we have those skills to interview people, ask them to tell us all about what it looks like from their perspective. And because this was an extraordinary event, we wanted to preserve these experiences at the time that they were going on, and then also present some resources which might be of support and might also influence how services were organised. So that was what we were trying to do. And of course, very quickly, along with the unprecedented numbers of people, and the unprecedented numbers of people in hospital with the same condition. I mean, normally, not that it's normal to end up in an intensive care unit, but, if you are in an intensive care unit, the chances are there will be people around you with a whole range of different reasons for being there. And this was extraordinary. It was, people who were all in hospital with the same thing. It also very quickly drew attention to, something that won't be a surprise to most of the people on the call, the incredible inequality in our society, and the unequal impacts of COVID were immediately very apparent in who was being exposed, who was getting ill, who was being hospitalised, and also who was dying. So that was something that clearly needed a lot more attention, and we are just one among many groups who were looking at those factors. And then the emergence of long COVID, and this was really, really interesting in that the realization that people were not getting better within the first couple of weeks as we'd all been hoping, and the fact that it was very much people connecting online that surfaced the fact that there was this strange long-term reaction to having had COVID. So in all kinds of ways, this was, very interesting in terms of health policy and also sociologically. So we wanted to do some research here. Next slide, please. Thank you. So most of the early research was focusing on the numbers, but we wanted to understand the stories and lived experience of the pandemic. So next one. Now, all of these studies used the same method. So this is why we were able to work together so well. And actually, we've got colleagues in a dozen other countries who have used the same methods that our research group in Oxford has developed. I mean, it's qualitative research. You ask people to talk to you, but we've got particular ways of doing things so that we can consent and copyright interviews to be used in a number of different ways. So the studies all use the same methods. We were seeking national samples and really aiming for diversity. But the fact that we collaborate with the DIPEX charity that runs the Health Talk platform means that we were able to disseminate this rigorous social science informed qualitative research about people's experiences on a public facing platform. And that's really what we're celebrating today. There will be many other things we're doing and are doing and have been doing with these data, but it's the launch of the final of these 4 collections. It's a multimedia online resource. It's intended for patients and the public. It's also used very widely for learning and teaching, service improvement initiatives, policymakers, and pretty much anybody who wants to consult a well, carefully collected and analysed sample of narrative interviews. So we've been working, my research group in Oxford has been working with the charity since the turn of the century. I actually started doing this work in the last century. I say that very often. I love saying it. And we've published over 130 of our studies on the Health Talk platform. Okay, next slide, please. All right, so what you're going to hear from now, so that's just a very general bit of background. I can witter on for ages about the methods behind our projects, but I think what you're here for is to hear about what we found. And we're going to have 4 talks, which focus on the 4 different studies, which can be summarised as about variation, about severity, about duration, and long COVID and family dynamics. So next slide, please. And this is quite unusual for qualitative research, that our wonderful research teams have managed to interview 225 people across the 4 studies. And as well as these 4 new sections on the Health Talk website, we're also developing catalyst films with extracts from interviews which can be used for service improvement, the theatre workshops with practitioners. We've got lots of academic papers in the pipeline and a methods paper. And we're working on a comparison with the 10 other countries in our collaborators who have been doing very similar interviews. And of course, all of the material will be archived in the University of Oxford and available for secondary analysis, teaching, broadcasting, further publications. Okay, and we'll come back to some of these ideas about what we will be doing shortly. First of all, let me pass over to the first of our 4 talks, which is going to be Annalika, who's talking about experiences of intensive care and COVID. Thanks, Annalika.
Thank you so much, Sue. And very delighted to be here to talk about this important work. So I'm presenting on behalf of my colleague Lisa Hinton and myself, and Lisa and I in the past 2 years sought to capture, 3 years now, 2.5, with the support of an extraordinary advisory panel and many others, experiences of intensive care with COVID. So for this study, we conducted 44 interviews, 32 with patients who have been critically ill with COVID-19, and 12 with family members and close friends, of whom 4 were bereaved. So we're very grateful to all those who were willing to share their story with us, and we're very, very happy to see some of them here today. So ICU COVID patients are, in one important respect, distinct from other COVID patients, and that is in terms of severity. They've been admitted to intensive care and and family members had someone close to them in ICU. Many were ventilated, mechanically or otherwise, or both, and many did not survive. All others faced a long and difficult recovery. COVID patients in ICU also differed in important ways from pre-pandemic ICU patients. On average, COVID ICU patients had longer hospital stays, and they were admitted under the hospital ban. And other ICU patients are generally sedated throughout. COVID patients in ICU were often conscious for protracted periods of time, and therefore witness to what happened to them and around them. Those who survived faced treatment and recovery in an overwhelmed healthcare system. So I want to highlight 3 themes that stood out from our work. Firstly, the very high degree of social isolation that people experienced. The visitor ban that was implemented at the start of the pandemic across NHS hospitals in the UK to prevent transmission from and to hospital visitors had devastating unintended consequences and caused distress to patients, family and staff alike. Although telephone, video conferencing calls and family liaison were greatly appreciated by patients and family members, they could never fully replace physically being together. Secondly, COVID-19 and ICU entailed an unanticipated and difficult confrontation with mortality. Patients were isolated from non-COVID patients as much as possible, and so those we interviewed described being surrounded by patients with the same conditions, often leading them to compare their progress or deterioration to their own. That many fellow patients died was demoralizing and highly distressing, and it had long-term consequences for many. Finally, there was a big variety in experiences with follow-up care. In March 2020, COVID-19 specific care and support services did not yet exist. It was initially unclear what needs recovering COVID-19 patients would have, and differences in care were enlarged as some could draw on personal networks and go private, whereas others could not. Nevertheless, gratitude for NHS workers was central to what people told us, as everybody recognised what an unprecedented and difficult time it was. So to close, I'd like to show you a clip that illustrates some of these experiences of the confrontation with mortality and separation from loved ones. It's part of an interview I did with Stephanie and her husband Peter, who was admitted to intensive care in September 2020. And I think this clip really powerfully captures the extraordinary time that we all lived through and the experience that manifested for patients and family members who spent time in hospital or at home during the visitor ban. Thank you.
Peter and I we're very close and we spend a lot of our time together. So it was horrible. I felt like I'd lost my right arm, you know, he wasn't there. I felt very, very much alone. In fact, I said to my friends, I could be, and my daughters even, I could be in a room with 1 million people and I still felt so alone. I really, really did. That's just the way I felt. It didn't make any difference who I was with. I was alone. So no one could have helped me really then. But I remember when this nurse came down and met me in reception, and she was the nurse looking after him on that day. I was so jealous of her because I was thinking, she's actually getting to spend time with him and she's with him. He can see him and I can't. I'm not allowed to. And it felt so unfair, you know, and I wanted to sort of like just run past her and go up to intensive care and be with him and hold his hand, but I knew obviously I couldn't, and that was quite an overwhelming feeling really, you know, the fact that another human being was preventing, or several human beings were preventing me from actually being with him, but obviously I knew why, so I wouldn't have changed it. But that was really, really difficult.
Thank you. And I think I hand over there. Thank you so much.
So thank you, everybody. And I'm really pleased to have the opportunity to just highlight the Health Talk site on long COVID in adults on behalf of my colleagues, some of whom are on the call. Alice McLean and Callum O'Dwyer and Louise Lowcock and many others. This site was actually launched at the beginning of January. And what I thought I'd do today is just try and give you an overview of the key topics which came up, and really happy to answer in a lot more detail further down the line. Before moving on to those topics, I'd just like to say that in many ways I found this one of the most affecting studies that I've worked on in my career, because the way that we interviewed people was online like this, partly to make it possible for people who were feeling really, really affected by their long COVID to be able to participate, sometimes in short interviews on repeated occasions to take account of their symptoms. But there was a real intimacy because you're looking so close to somebody on the screen in doing these interviews, which really brought home very much just the level of suffering that a lot of people with long COVID have had to experience over these past 3 years. So if we could move on to the next slide, I can highlight the key topics which are on the site, and we've got 21 different topic summaries which cover 8 main areas. So we did have some discussion about what long COVID should be called, but I'm not going to focus on that just at the moment. Our topic summary on long COVID symptoms just shows the extraordinary range of symptoms which people experienced, and the ways in which people really struggled to make sense of the fluctuating symptoms that they had and the range of symptoms that they had, and symptoms which they themselves see would be easy for others to disbelieve, because in many cases they were such a bizarre as well as deeply affecting constellation of symptoms. We also talked about the ways in the topic summaries covers the ways in which people lived with and managed these symptoms. People's lives were devastated often, and if not absolutely devastated, they were very, very severely disrupted over very long periods of time. So a lot of the people we spoke to had been ill for at least a year. Some of them have now been ill for almost 3. So the topics covered how they managed day to day, some of the medications and the supplements that they had tried using, because of course, as a novel illness, there was very little either in the public domain or known amongst healthcare professionals about how best to treat people and support them with their long COVID symptoms. There's a section on physical, occupational and talking therapies that people used. And there's a section on the emotional impacts that were brought up for people, including in all of their day-to-day interactions with their family, close family members, and the loss of their relationships with so many other people. Very few of the people that we spoke to knew how far down a path of recovery they were, because it was still very early days for them. There was only 1 or 2 of the 60 or so people that we spoke to who felt that they were really coming out the other end of their long COVID. But nonetheless, we talk about people's thoughts about their recovery and what they see their futures as being and how it might be affected. And there's also a section on their own experiences of vaccination and vaccination decision making. There was some discussion at the time that we did the interviews, the last ones were done last year, about whether vaccination might exacerbate or improve people's symptoms if they had long COVID. The section on seeking help from healthcare professionals covers people's experiences of seeing the GP, of going to hospitals, either A&E or a few people with inpatient care. Some of our participants from England had the opportunity to go to long COVID clinics or different specialists, and there were other NHS referrals. And one of the things that was quite striking to us was how many people had been struggling so much on their own that they'd had to resort to various forms of private treatment at a very large cost to themselves. And again, a very, very striking feature from this section of the data was just how important it was for people to be believed when they went and presented these sometimes quite extraordinary sets of symptoms to the healthcare professionals that they'd seen. Savante will speak in a moment in much more detail about the impact of long COVID on family life, but we've included a short section here. And we've included a section on work and employment because many people's working lives were either truncated, finished, or affected in the short term. And in this section, we've completely anonymised people's contributions because we're conscious that people may not want to be recognised at work when they speak about these things. And we speak a bit about the financial implications and the implications for social interactions much more generally. And then, as with all of the other Health Talk sites, there's sections on sources of information that people have found useful. And of course, for long COVID, many of the online groups were an original lifeline for people, and some people have found that that's continued to help them. And then there's a section on messages for healthcare professionals and for other people with long COVID. So just to finish up, it's so difficult to choose one clip that encapsulates all that we've learned. But the clip that we've chosen is from a young woman who had been extremely active. She had two small children. She was working as a nurse and thought in the early course of the pandemic, because she was young, she probably was not at high risk of getting COVID or long-term effects of that. Her life has been really devastated in the short term. She's not able to do any of the things that she wants to do as a mother. She's had to miss out on so much of her experience of looking after her own children. And this particular clip just encapsulates not only how much her life has been devastated during the past year or so before the interview, but also how she feels about her future.
Yeah, I worry if they get COVID and be like me, because there has been talk of these like POTS and the things they've told me being genetic, and I think I'm gonna pass that on to them. Will they react badly? I worry that I'm not going to get better and it's going to be some sort of autoimmune condition and I'm not going to be here for me. And I worry that I'm going to stay as I am and never be able to be part of their lives. I worry my husband will want somebody else because, you know, I'm poorly and not bringing a lot to his life, but stress. So yeah, lots of worries financially. What am I going to do when my pay stops? And I worry I'll lose my nursing qualification if I can't get back soon. Yeah, 3 years, if you've not worked, you lose it. And I've done coming up 18 months, so
yeah,
lots of worries.
Thank you. So I'll hand over to the next person.
thank you, Kate. And that leads us on really nicely to the most recent study that's just been published on the Health Talk website over the weekend, which was long COVID in families. And this was funded by NIHR and focused more specifically on the impact of long COVID in families, and in particular looking at the experiences of children, teenagers, young people in their 20s and their parents. Just to kind of elaborate on that, we were really interested in that group of people in their 20s who may have had to return to their family home because of their long COVID, because they could no longer look after themselves. And we were interested in what effect that would have on family dynamics and young people kind of thinking about their future. So we did 73 interviews in total and covered a really wide range of experiences, just like the adult study that you saw just then, that focused on that impact on family life. We knew that, as with most chronic illnesses, much of the care happening for long COVID would be happening in the family home. And that was especially important for long COVID, where at the time of our application for this grant, there were very few care pathways available. And as we know now, those care pathways have received quite mixed responses from families across the UK. So as with all of our studies, we were guided by advisory panels that included people with lived experience of long COVID, and that really shaped the project right through to deciding which topics we included on the Health Talk website, how they were named, and so on. So these sorts of topics included not only the breadth of symptoms that people experienced, but also the mental health impact of having long COVID on a teenager or young person, the wider impact on the family in terms of how people have adapted within the home, how their caring roles have changed and how parents have been affected when their children have long COVID, but also when they have long COVID themselves. We looked at work and the wider impact of a parent who has long COVID and the impact on their work and what effect that has on the family, and also the financial impact on a household's resources. And focusing on that particular aspect was something that we did recently with the long COVID in adults study and submitted to the all-party parliamentary group call for evidence on the impact of, the all-party parliamentary group on coronavirus and their call for evidence on the impact of long COVID in work. Another thing we particularly focused on, and this is the subject of a paper that's just been submitted by our colleague Alice McLean, was the impact of long COVID in schooling and how peers have reacted to children's long COVID, how teachers have reacted, whether schools have been able to support families to accommodate their illness and disability, and so on. As Charlotte touched on in that clip just before, we also looked at the impact on relationships, the wider impact on the wider family's mental health, as well as people's experiences with accessing care and their thoughts on a very uncertain future. I'm going to turn now to one of our interviewees, Rosie, as she shares a little bit about her future, her disrupted life plans. So Rosie was nearing her final year at school, but was quite worried about the impact that this would have on her ability to plan far ahead and missing out on things that her friends would be doing at the same time.
It's really strange because there's so much going on, but then not at the same time. Like, I don't have all the stuff happening that used to happen, so I'm sort of worried about missing out on that. And there's like the aspect of school. I don't know what's going to happen with my AS levels, so I don't know whether I'm going to be able to do them this year or whether I'm going to have to just redo the year next year, and then I'll be a year behind, which is a bit upsetting because then all my friends will be in the year above and I won't have them in classes and stuff like that. It's mainly just upset that I miss out on things and I can't do everything that I want to do. And then going to do something and just knowing that after I'm going to feel terrible, which is not a nice feeling, really.
And I just want to also touch briefly on some key challenges and themes that we're reflecting on as a team at the moment in our current outputs. The first one being that real importance of being believed by peers, teachers, and health professionals, and the impact of that repeated gaslighting on children and young people. But in contrast, the empowerment that can happen when patients are believed and that kind of respectful co-experting that can happen when clinicians and patients can walk that journey, which is very uncertain, but can walk it together. Just touching on that, the very uncertain care pathways for paediatric long COVID in particular, the very disparate coverage across the UK. So with Rosie, when we did her interview, there were no long COVID clinics for children in Northern Ireland. I think at the time there were no long COVID clinics at all in Scotland. So it has been a real mixed bag in terms of what people can access across the country. the sort of the expectations versus reality of what actually then happens in a long COVID clinic once you get there, and the grappling that patients have to do with the fact that there are currently no treatments approved for use within the UK. I've already mentioned the difficulties that children and teenagers have had with school. There are obviously positive examples of this throughout the data as well. So there are, examples that we can learn from, but those are explored a lot more in the paper that Alice has in submission at the moment. That uncertain future at a time when in your life where there are lots of future plans, and this is the same for children, teenagers and young people in their 20s, that's a really key group we wanted to focus on, and is the subject of a particular analysis that we're working on at the moment, looking at people's disrupted life plans in their 20s with long COVID. And then one other thing that we're looking at is this idea around long COVID and inequalities, and whether families from minoritized ethnic groups are able to access the same care across the UK. And here, just before I move on to the last study, I just want to emphasize again that we've covered so much long COVID experience across this study and the adult study, and that potential for collaboration and fresh ideas on outputs and dissemination is huge. And as this has been very recently published, I really welcome your ideas on how these sorts of modules and our data can potentially be useful to you. And with that, I'll hand over to Anna, who will walk you through our last study.
Thank you, Savante. So my name is Anna Dowrick, and I was one of the researchers on this project, and I was collecting data alongside Tanvi Rai, Kaveri Qureshi, and Heather Munro. And if you go on to the next slide, this work was kindly funded by the Economic and Social Research Council. And then the next one, thank you. So whereas the previous studies that we've heard about were each looking at particular aspects of COVID experiences, so ICU experiences and different manifestation or different impacts of long COVID, for this particular project, we were examining how existing social and structural inequalities in contemporary Britain shape pandemic experiences more broadly. So you'll remember back in 2020, there was widespread reporting of the unequal impacts of the pandemic, and most notably, I think this was in the stark representation of deaths broken down by ethnicity. So during the first 3 waves of the pandemic, deaths were significantly higher among Black and South Asian communities, particularly people of Bangladeshi and Pakistani ethnicities. So for this project, we really wanted to understand people's perspectives on inequality during the pandemic, with a focus on hearing from members of minority communities and communities that were most severely impacted in these early stages. And we spoke to 70 people who'd been ill with COVID between March 2020 and December 2021. And 2/3 of those people self-identified as from an ethnic or a religious minority group. And we discussed how they navigated COVID risks in everyday life, how they felt about and responded to pandemic messaging, different guidelines and restrictions, and what their experiences of illness and recovery were. And so these participants highlighted that the pandemic was just one manifestation of ongoing challenges faced by minority groups. And they also explained the complexity of raising awareness about these types of inequalities. So, for example, people we spoke with felt that media reporting on how minority communities were more affected had the unfortunate consequence of actually exacerbating stigma against ethnic minorities, as we'll show in a clip now, if you'd move on, Savante. So in this clip, Shireen, a Bangladeshi woman in her 60s, explains that this kind of this exacerbation in more detail.
I think COVID really affected our community, and that's why people are keep hiding it, because saying, oh, we are poison. If you go near people, that's it, we are very affected. We are the one who's going to spread the germs around, you know. So obviously that's how media and the public are actually portraying in the community, you know. So if you had never dealt with any BME people, never come in touch, you hear this in the news, what do you hear? You hear the negative things goes into your head. So as soon as you see a BME where a black person on the street, you want to be away from them. They're the most affected person, that's it. If you go near them, that's it, you're killed next day.
And the next slide, please. So to conclude, this work reinforces understanding that structural racism has an ongoing and pernicious impact on experiences of health and illness. And to just put it simply, not everyone has the same opportunities to protect themselves from COVID or to take time to fully recover from illness. And this is connected to a wide range of factors, including the nature of people's employment, financial situations, household structures, caring responsibilities, and which are all kind of shaped by structural inequalities. And importantly, some of the people we spoke to from ethnic or religious minorities felt that they weren't believed or taken seriously when seeking help. And this covers both kind of acute COVID and then long COVID experiences. And they felt they had to do extra or additional work to prove the severity of their illness in order to get support. This in itself fosters mistrust in healthcare services, which in turn affects willingness to kind of seek help and engage in public health practices like vaccination. So as we continue to live with COVID, addressing these inequalities really needs to be a central focus of government and NHS strategies. And that's our presentations done, I think, on the individual studies.
It is. Thank you so much, and thank you to Annalika Dryson, Kate Hunt, and Savonte Wild, and Anna Dowrick as well for those really tantalising, I hope, extracts from the findings. This is a massive amount of work, and I just wanted to very quickly, before I hand over to the discussants, so Nisreen and Trish, in your starting blocks, please. There are a few ideas that we have about what we're doing next. Now, I really hope that people who are on this call might have a look at the Health Talk sections on COVID, these 4 sections, and perhaps recommend looking at them to other people who might benefit. I think, we've had some stuff in the chat about, how powerful, but also, how reassuring and supportive it can be to look at how other people are experiencing even rather unpleasant things. To know that you're not alone can be very, very reassuring.